From the machine? So you might notice something is happening. It's called a technical issue. It's the first time it ever happens in any conference. So, oh no. Oh, it is? Okay, great. I just had to start talking for the thing to shut me up. I'm going to share this. It's for your name. So you can just put one or two tag and your name and pronouns if you want to put your country or your organization. So just pass them around. And there was something else, and now I forgot. Somebody asked me something, I forgot. Anyway, yes. Someone asked me, can I take a program? Yes. See, thank you. So a couple of people, one today and one before, asked me, so a couple of people asked me, what is this on the program? So the main aim of this drawing is to make you talk and discuss what is this. And I don't know if anybody knows what it is, apart from the person in the back who knows. We here have soft tampon, Raven. What is it? It's a sponge. So it's a homemade sponge. It's not a marshmallow, like somebody thought it was a marshmallow. You don't put marshmallow there. And that's it. So now we're going to go to the panel, which is not a panel, which is Elizabeth. And we're very excited because, to give you a bit of background, it's okay if I give a bit of background? Okay. This year, ESWA received funding from VIV. Actually, I don't know, I'm supposed to be here for the camera or something? Yes. So this year, ESWA received its first funding from VIV, which is a pharmaceutical company. I don't know if somebody from VIV is here. They might arrive this week. And this allowed us to do several activities, including our training in Portugal, beginning of the year, for trans sex workers, another training for male sex workers. We are publishing several resources on male and trans sex workers. And one of the main, this conference as well is covered through this grant from VIV. And we also decided to work on stigma and discrimination faced by sex workers in healthcare. And this is what actually today is all about. So starting now until 6 p.m. today, the day is mostly focused on stigma and discrimination faced by sex workers in healthcare. So our first speaker is going to be Elizabeth, who kindly joined us in September to finalize the research, which was started by Jules James, one of our team members who has been on sick leave, and she will come a bit later, I hope. So we developed this research that Elizabeth will explain a bit more. And we'll then have Layla and Mark, right, presenting on their work as well with medical students, tackling stigma and discrimination. We then have lunch break. Then we have a panel of experts and researchers discussing their own research on stigma and discrimination. It's all in the program. And then the final panel will be sex workers activists with different identities and different backgrounds talking about how they understand stigma and discrimination, how it impacted their own lives, and how they recommend ways to tackle stigma and discrimination. So, are we good? Yay! So, Elizabeth, I'll let you... I think you have... you need a microphone, but you also need to be... Is she visible in the camera? It's automatic. Cool. And the research is available. We printed some copies there. They're all at the back. So you can get it signed by Elizabeth. Thank you. Bye.
Hi, everyone. The computer system was discriminating against my laptop, so I will be filing a complaint on that ground. I am Irish, in case the hair color didn't give me away, but I live in Switzerland. Don't ask why, I'm still unsure myself. But speaking of Switzerland, I brought some Swiss chocolate for everyone to enjoy. It is Well, I'm not sure there'll be enough for everyone, so there might be a Hunger Games situation in the room, but it's here. I'll pass it around after. And it is scientifically known that it will make this presentation more enjoyable to eat with chocolate. And so if the leopard print didn't give me away, I am a researcher, but I'm also a pro-dom. And like in my own practice, I frequently wear latex gloves in the interest of safety. But unlike the physician in the opening quote of the title of our research, I only wear one pair, not two. Yes, I did think of this transition during the break. So the title of the report from the research that Luca introduced is Two Pairs of Gloves, Sex Workers' Experiences of Stigma and Discrimination in Healthcare Settings in Europe. And this quote referred to one experience that a respondent shared with us in which they were undergoing a medical exam and the physician wore two pairs of gloves. So this is just a bit of an introduction. I think Luca has sort of covered it. But one thing I think that's important is that there was an intern working with ESWA who conducted a systematic review looking at experiences of stigma and discrimination in healthcare. And the findings were that there were very little research coming from the European context. So this was, again, one of the rationales for wanting to undertake this research. And so in doing so, we also wanted to consider the impacts of multiple marginalization in sex workers and how these play out in healthcare settings. So there was the online survey that was launched. It was available in 4 languages. That was earlier this year. This is just some boring procedural info regarding the methods. So there was like a combination of descriptive statistics and then text-based analysis, for which I used a platform called NVivo, and using basically like bottom-up and top-down coding, so looking at having a frame existing and then also looking at themes that emerged themselves in the data. And one thing I think that was unique in this process was that we had a validation workshop as part of the Red Umbrella Academy in Warsaw earlier this year. So we were able to gather the feedback of a lot of participants. Some of them are here today. So having more, sureness in the findings, being more reliable, and then having more relevance to our communities as well. So the framework that we chose to sort of embed the research or analyze the research within is a framework that's known as minority stress. So this was a framework that was created originally to look at issues impacting LGBTQI communities. It was, I think, developed by a US-based researcher to explain why we saw higher rates of physical and mental health conditions in lesbian, gay populations, and then it was extended to trans populations. But it is essentially a fancy way of saying that our environments and the things we live every day impact upon our health. So you have essentially external minority stress, so that's things that we are subject to due to having a minority identity, in this case, sex work or being a sex worker. And then internal minority stress, which is the processes through which the external becomes internalized, and we then may start to, let's say, turn that discrimination inward, even if unconscious. And then all of these things amount to our health, essentially, and the health of our communities. So that's sort of how we'll be structuring the results. So that's a little bit more about sex work and minority stress. So moving on to the results. Here you will see essentially which countries are represented. If you want to look more granularly into any of the graphs, I hope there's still some reports available that Luca have printed, so you can have a look at those, because I won't be, going into every graph that we have, because we have quite a lot. But this is just to show a breakdown of essentially which countries sex workers who responded to the survey were living. And when you see this little N number, that essentially just tells you how many people are in a data set. So in this case, there was 70 sex workers that responded to the survey. So here is just a little bit more about the breakdown of the legal frameworks from or among respondents to the survey. So we had 10% in a decriminalized setting, which in this case is Belgium. Of course, I know, and it's discussed in the results, that the decriminalization is very recent and is still in implementation phase, so that might, impact how we can interpret the results and so forth. Same thing, we had a couple of settings in which sex work was legalized, and then others with various, tiers of criminalization, including many which criminalize buyers. So there was a range of forms of sex work among participants. You can see a little snippet of these here, and a range of places in which respondents conducted their work. I think a nice thing to note is that the total years of experience in sex work among the sample was 508 years. So that really shows the wealth of experience among the respondents to this survey. And essentially means that we can generalize the results to a really wide range of sex workers doing a wide range of different forms of sex work and operating in different settings, whether indoor or outdoor and so forth, or online. So overall, 43% of respondents said that they had experienced stigma. 40% had experienced both stigma and discrimination. 6% weren't sure. 6% said they had not experienced stigma or discrimination. And 4% had experienced just discrimination on its own. So when adding up these total reported experiences of stigma and discrimination, there was a total of 667 instances reported. That's among those that could be quantified, because there were other responses that were given saying things like too many times to count, or 100 plus times. So this is sort of conservative. And you can have a look more in the report about, again, like the identities of workers who responded to the survey. So you can see the breakdowns, who's represented. There's a large number of disabled sex workers represented, some racialized sex workers who are migrants, parent sex workers who use drugs, etc. So you can have a look about how the results correspond to them. But these are some interesting findings to share. So 100% of the respondents who were racialized, migrants, or living with HIV reported experiencing stigma or discrimination, or both. 92% of trans or gender non-binary participants reported experiencing stigma or discrimination, or both. And 91% of sex workers who are disabled reported experiencing stigma or discrimination, or both. Shocked? So here is a look at the experiences of stigma and discrimination by legal framework. So this looks a bit complicated and sort of fidgety, but I think what is the important takeaway to focus on with this slide is that it looks like the legal framework doesn't necessarily impact experiences of stigma or discrimination. And again, that may be for a number of factors, because decrim is very recent addition to Belgium, so therefore it might not have had time to make effect. Or if that has had time to make effect, we don't know if that already influences the attitudes of healthcare providers. So these are kind of the unknowns. But it shows that essentially the legal framework is not the only culprit, let's say, in perpetuating stigma against our communities. We also need to look at wider sort of framing, discourse, and so forth. So that's sort of an interesting, I think, takeaway of this report. But I just want to say that it's not, this isn't a statistical analysis because the sample size was too small. So, yes? Yes, thank you. We just gave a definition of stigma that was coming from a dictionary because we wanted it to be accessible to the community, but we also asked the community if they had their own definitions of stigma that they would like to share with us, and many of them did, so I can give you a couple examples of the definitions that they shared with us. But essentially we pointed to stigma as a societal problem, moving away from the initial conceptualization of stigma as being individualized, as being something that has its roots in society and in cycles of power and so forth. But so some of the definitions that respondents gave of stigma themselves were that stigma was structural othering, was social exile, and was about a politics of lower expectations. So I think those were very interesting to see the actual understandings of stigma among the respondents as well. So you can look at the report if you want to see the exact definition we gave, but it wasn't coming from an academic source.
No, I understand that because it's very difficult, I think, to research that. So stigma was more, discrimination was more that people directly experience. So how should I interpret the difference?
Oh, you mean how they're distinguished from one another? Yes, good point. I would need to look in the methodology more specifically to see how that was operationalized. I think it was that discrimination was more of an overt act and stigma was more relating to the attitude potentially. But again, I mean, I think these things are interrelated, and I think that sex workers responded based on, their own understandings of kind of what was what. But I think the distinction between both is probably not necessarily the most important kind of takeaway. But yeah, good point about, the interconnectedness and the confusion. Maybe we can save the questions for the end of the... Pardon? Yeah? Great, thanks. Yeah, I'm sorry, bear with me on that because I came into the project at a later stage, so some of the, if it relates to the methodology and things, I'm not as up to speed. But yeah, if that's okay, maybe we'll do questions toward the end, just because then maybe things will be answered as we go along. Great. Okay, so this shows the breakdown of services in which stigma or discrimination were experienced. As you can see, essentially a wide range of services, the most frequent being GPs. Secondly, we then have sexual reproductive health care and mental health care. Again, I think no big surprise for many of us in the room that have personal experiences on this subject. Hospitals, specialized healthcare, and then other healthcare providers. So things in the other healthcare provider category was blood donation clinics, and I think there was some other more like community-based centers as well. So in terms of the external minority stress that we saw reported, so we have a couple of things that I'll point to, but these essentially round up sort of all of the themes that came out of the analysis of the answers given by respondents. So we have basically an excessive focus on sex work. So it was seen that if you would arrive at the doctor and you have a cold, it's because you do sex work. Any potential problem or grievance that you might have, complaint that you might present with, would always be attributed back to the fact of being a sex worker. And basically that would come to cloud any other kind of context or identity within a patient's lives. So this sort of is pointing to the fact that sex work was seen as encompassing or totalizing or overshadowed any other kind of problem that respondents had. And again, sex work was then seen as itself a very homogeneous and uniform type of identity. So all sex workers were seen as the same, as doing the same forms of sex work in the same places and having the same healthcare needs, basically. And the trend seemed to be that providers would, equate sex work with in-person, indoor or outdoor full service work, and usually they would see sex workers exclusively as being cisgender women. So we have a tendency for healthcare providers to divorce sex work from external and economic circumstances. So again, kind of no understanding of why persons engage in sex work, what their needs might be in this regard. And this led to giving advice that was unhelpful and unsolicited, and overall paternalizing. And this sort of then connected to a form of double standard, whereby you would have forms of advice that were given to sex workers that would not be given to other professions, let's say. And then, of course, we have a lot of fetishization that was reported, linked back to this sort of understanding of sex workers as being public property in a sense. Gatekeeping care, so making sex workers jump through all these extra hurdles or hoops in order to have their care needs met. General dehumanization, dismissal of lived experience, of knowledge of bodies and so forth. Pathologization, so sex workers were seen as, sex work was seen as a manifestation of pathology and also a conduit to further mental health conditions. So if you were doing sex work, it must be because you've had XYZ trauma in your past, and if you're doing sex work, you will have XYZ trauma in your future. And this relates as well to sex workers being perceived as risks, both themselves in terms of risks that need to be managed. We heard from the presentation earlier about how this emerged in the public discourse as the vector of disease narrative, but also sex work as being inherently risky, leading to violence risks, health risks, risks to moral standing, let's say, linked to, again, like spirituality, things like this, relationships, how societal standards play into relationships, how we're supposed to relate, and that sex workers were not in a position to form the types of relationships that are accepted in dominant society. So you can see here how these sort of played out in responses. The most frequently cited experience was being asked inappropriate questions, which I think is not at all surprising. This was followed by being advised to stop doing sex work, but in ways that were seen as both patronizing and generally unhelpful, in that no other material resources were offered for anyone who did have an interest in maybe pursuing another form of revenue than sex work. Followed by this, we have gossiping, breaches of confidentiality, such as marks on medical files and so forth, avoiding of contact, verbal harassment, being outed, having treatment be deferred to specific times, and so forth. So I'll just give you a snippet of quotes that relate to the themes that were discussed among participants. All the participants have given their consent to share quotes as well. So, they wanted me to do therapy for the pain my work caused, even though I never asked for it. They asked me how I could look at myself in the mirror. There is no recognition that it can be a job, no more, no less, and not necessarily the manifestation of my childhood traumas or whatever. They only see the sex worker in me. Their point of view is printed in the law. Their point of view on sex work is printed in the law. I was stressed because I had to earn a certain amount of money before traveling. The gyno interpreted it as though I was pressuring myself to sell sex. When I showed up to the emergency room with bleeding, a gynecologist requested STI testing. Even though I told her I'd been tested a couple of days ago, she refused to further investigate without running the tests again first. I've been refused therapy in the past because doing sex work means I'm complex needs. They always book an hour for testing to first have a talk. Kind of an attitude like, wow, it's not every day you get to meet a prostitute. The comments are meant to be supportive, but they just make me feel isolated. So this linked to instances where there was seen to be a sort of empowerment or like affirming narrative in a practice, but this clearly lacked like an overall understanding of context, of holisticness around sex work, and was just playing into one type of narrative that we often see. My bed and all belongings stayed in the hallway for the duration of the stay. I called my appointments with my therapist the tribunal. The doctor refused to refer me to physio for chronic leg pain because just stop wearing heels. This sort of links to the double standards that we're seeing with forms of sexualized labor, because as we know, this type of advice would never be offered to an athlete, for example, or let's say someone who does professional ballet, stop wearing ballet shoes and so forth. So really a lack of understanding of sex workers' healthcare needs and the choices that we make. Like we are all just empty shells. Again, linking back to general stereotyping surrounding who does sex work, what our capacities are, etc., and just a uniform sort of identity being cast upon all sex workers. Psych ward staff told me that the hospital is wasting space and money on me. Hearing a doctor tell me I need a man with a good for treatment was something else. So this will come to a little bit further in the section that's looking at intersecting forms of discrimination, and particularly an example, obviously, of cis-sexism and heteronormativity. So when responding to whether stigma was decreasing or increasing, this was sort of mixed results. I think participants felt that it wasn't certain one way or the other, but maybe there was overall more awareness around sex work, but that this didn't necessarily lead to more positive attitudes on behalf of healthcare providers. So perhaps there was a tendency to be more open in talking about it, but not necessarily whether that influenced how it was received. So in terms of then how stigma played out internally among respondents, we saw that workers would come essentially to anticipate forms of rejection, which then causes us to want to hide our identities, conceal our identities. And we then become bound up in these processes of thinking, okay, do we disclose or not? And how this then leads to different kind of hypervigilance and so forth, always being on guard, thinking about, is it safe to disclose? Is it not? And then in some instances, this can contribute or lead to sort of self-blame or internalization of stigma. And this sort of fear of, disclosure or preoccupation with concealing sex work or sex work identity led to a lot of fears to actually engage fully in consultations. So maybe not wanting to engage fully in every aspect of the exam, or just being vague and not actually really being able to have that type of dialogue with a healthcare provider that would lead to having needs met. So I generally talk about any topic that affects me, preparing for the negative consequences. So again, all about the sort of expectation that stigma is going to occur, and the sort of mental preparation it takes to do that and expose yourself to those settings. I can't let the healthcare see me naked because I don't want them to see my C-section scar. We'll talk more about specifically forms of stigma experienced by parents, but I think this particularly illustrates the extent to which workers could not actually engage in the types of examinations they need in order to meet their needs. I have to hide this fact, sex work, in therapy, which is making it pointless. It felt unfair and scary to understand that I internalize and accept quicker than I speak up, so relating to that sort of internalization of stigma. And when asked if, after experiencing stigma, whether workers changed their behavior when going back to healthcare services, 85% said yes, and 15% said no. So that shows the extent to which the external then leaks into the internal. And one worker said, "I go there with my stone face on because I don't want them to break me down again." So again, we see that 69% of sex workers chose not to disclose their sex work in a healthcare setting. 95% of those who use drugs chose not to disclose their drug use. 67% of those with other identities chose not to disclose about those. 38% their sexual identity, 30% gender identity, 33% migration status, 52% disability, and 40% HIV status. So here we see whether disclosure, wanting to disclose sex work, differed depending on legal settings. And what's interesting about this is that in Belgium, the only decriminalized setting, we see that there is a greater willingness to disclose rather than hide sex work. Again, we don't know yet how to interpret this because it's very recent, but it is interesting nonetheless. So then in terms of intersecting discrimination, all the usual culprits, I'm sure everyone is very familiar: ableism, heteronormativity, racism, medical sexism, cis-sexism, fat phobia, trans misogyny, language barriers, xenophobia, stereotyping of mental health statuses, legal gender markers or identification being a barrier, decisions around whether to expose other minority identities, transphobia, and so forth. So just a couple of quotes. Oh, they've been cut off at the side. Sorry about that. So there's this assumption that disabled people don't have a sexual life. I'm always going to avoid saying that I'm a sex worker and smoke weed. If I say one, I won't say the other. They refused to run certain tests because I'm a lesbian and hadn't outed myself as a sex worker. They told me that I was infectious even though I take antiretrovirals. You can't be a sex worker if you are autistic. Your father must be ashamed of you, no? This was a comment made by my former GP because I'm of Moroccan and Muslim origin. So showing the ways in which other identities intersecting with whorephobia and then playing out in healthcare settings. So we also asked sex workers about their actions to challenge stigma. So when given the chance, 54% of workers did take action to challenge stigma. And I think what is, again, very interesting is that when this was broken down by legal setting, decriminalization was the only setting in which workers took action more so than did not want to take action. And again, this might be because they know that there won't necessarily be legal consequences, or it could relate to other factors, but that requires definitely more examination in the future. So why did people feel not able to take action? 71% said they didn't have the time or energy, the resources. 62% said that they believed it wouldn't change anything. 36% were scared of ramifications, and 38% thought they would not be listened to. So this shows what people did after experiencing stigma or discrimination, and a lot decided not to go back to the same healthcare provider, but then many also stated that they have no choice. And obviously this relates back to like privilege, individual agency, financial resources, other resources, whether or not you could change providers, healthcare, insurance, healthcare systems, and so forth. So a lot of factors went into, you know, constraining or giving workers agency over how they reacted to stigma. And the coping strategies that communities put in place. A really large coping strategy was actually just to educate. Again, I'm sure many people won't find that surprising, but to speak back to healthcare staff providers when they experience something. And this was, you know, done concertedly as wanting to make changes for the community. So some would, you know, specifically affirm their sex worker identity, whether to themselves or in front of providers. There was a wanting and a willingness to recognize sex workers as experts, but this came with the downside of a lot of education fatigue, resource drains on sex worker communities, on individual sex workers, was linked to also expectations of uncompensated labor, and so forth. Sometimes workers simply preferred to adapt to the providers and just do what they needed to do in order to get the health care that they were seeking. Some actually saw, you know, disengaging with services as being very strategic and shielding themselves for harm and making these kinds of decisions about delaying healthcare until they felt more emotionally able to deal with consequences of stigma and discrimination, which obviously has impacts on physical health. But this was what was reported. Even just something like being emotionally detached when attending a healthcare appointment, and of course the importance of sex worker community networks emerged as very relevant. So in cases, sex workers would just go within their community, maybe to those that had some kind of medical knowledge. They would share resources within the community of which providers were seen as safe or which providers people had had a good experience with, and so forth. So 72% of workers submitted a complaint, and 28% did not. So with regards to the complaint processes, factors that influenced whether people wanted to engage in those or not were things like the self-dismissal of seriousness, so thinking like, oh, it was just a little remark, or I didn't think about it too much at the time. So again, that sort of way in which we might internalize these types of everyday microaggressions as, and then becoming, you know, normalized. There being a lack of paper trails, so, you know, saying things like, well, it would be my word against those, against theirs, and who has, you know, more power in those types of situations. Some gatekeeping of complaints mechanisms. So, for example, if asking for the names of the healthcare providers, they would say like, well, that's confidential, we can't provide you the names of who was on the shift last night and so forth. So really wanting to block actually engaging in the mechanisms. The accessibility of the mechanisms, the fact that they weren't advertised, the fact that they were online, very lengthy, things like that. Fear of retaliation was a big one, and especially among workers who maybe, you know, were parents or whose migration status was not regularized. They would fear like having this come back against them. Again, this was similar for patients specifically in mental health care or hospitalized, because they felt like the power dynamic was much greater and that the providers were in a position to influence the future of their health care, so they preferred to not move forward with a complaint. And then many just, you know, thought that it wasn't going to be of use, essentially. So again, you can see here that 52% were afraid of facing more stigma or discrimination. 40% thought it wouldn't be followed up. 33% said that the process was too complicated. 37% it wasn't possible, and so forth. So this relates to a lot of the community-led education. When asked if I was being forced, I explained the forces of capitalism. So in terms of health outcomes, we saw that this discrimination and stigma impacted on both physical and mental health. So you had things like an overall delays in getting the healthcare people needed, lack of being able to fully participate and make informed decisions because they didn't feel like they could be honest and open with providers, and then just generally, things like delaying care and so forth, having worse healthcare outcomes as a result. Yeah, so this respondent said that actually my appointments at service are worse for my mental health than any of my clients ever have been. And overall, 59% of respondents said that their health was negatively impacted by stopping going to a healthcare provider. That's for those who stopped going to healthcare providers. So this was a representative word cloud of how workers felt after experiencing stigma or discrimination. So you can see that anger was the most commonly represented response. But we also have things like frustration, humiliation, offense, annoyance, feeling small, feeling misunderstood, feeling abandoned, discouraged, excluded, shamed, saddened, unseen, untrusting, dismissed, disempowered, stressed, worthless, and so on. So one worker said that above all, it was the feeling of being nothing else. As soon as I talked about my job, all of the exchanges revolve around it. And another respondent said that I felt robbed of a right to feel more secure in my practice, to feel safe with doctors, and to ask them for what I need. So the main takeaway points from all of this, very heavy slides and graphs and so forth. I think this research highlights the negative attitudes that still very much pervade in healthcare settings in Europe, which again I think is not surprising for many of us, but it's nice to have things written down in a way that can be shared and then contribute to an evidence base. It complements the research which shows that healthcare systems in general stigmatize sex workers and therefore impact on our access to healthcare and health outcomes. It aligns with evidence that shows healthcare itself can be a barrier to accessing healthcare. Again, because not wanting to engage in further consultations because of previous experiences of friends, and so forth. It reinforces evidence about the impact of identity concealment and expectations of rejection that workers face. So expecting to be rejected or expecting stigma and discrimination can dissuade workers from disclosing, and then hesitancy to disclose can limit opportunities to meet healthcare needs. And then also it gives a bit more understanding about decision-making processes surrounding disclosure in healthcare, what could potentially help workers to feel safe disclosing, and this can be used to help support interventions in educating healthcare providers, in shaping service management, and so forth. So many of these things you can see in the recommendations. So it also shows, again, and builds a lot around the evidence base of sex workers who are multiply marginalized and how whorephobia intersects with other systems of oppression in healthcare, which there's not a lot of research conducted on currently. So we felt that that was quite important. And it shows the huge role that sex worker rights community organizations have in actually bridging these health inequalities that exist because of stigma in healthcare settings. And the role that we can have in training healthcare providers, which Layla and Mark will speak with you about very shortly. And again, it shows what strategies sex workers use to actually cope with stigma and discrimination. So in terms of the relevance of the legal framework, we saw quite clearly that sex workers who were facing criminalisation referred directly to the legal framework as a deterrent of disclosing, because they feared having, a negative impact. Belgium was the only context in which workers reported feeling more comfortable than not both disclosing their sex work and taking actions to challenge stigma and discrimination. And as we mentioned, that needs to be interpreted with a bit of caution because we don't know yet what that is attributed to, but it could be decrim, it could be having a great number of community organizations that helped push for decrim, and so forth. So the strengths of this research was that it was sex worker-led, and this may have also decreased bias in that the community were maybe more open to sharing their experiences with us, also due to the anonymity that was given by the online survey. Some respondents mentioned that they'd actually not had an opportunity to share their experiences and that they found this was a source of catharsis for them. So it shows really the need to have more avenues for workers to be treated as the experts we are in our own experiences. There was a variety of legal frameworks and forms of sex work covered. So we have a good ability to generalize and say stigma is not only affecting one form of sex worker or those who do one kind of sex work, it's really across the bat. But of course, there are more particular forms of stigma that do exist and that were reported that you'll see in the longer report. It had an intersectional lens. It was the first piece of research looking at strategies to cope with stigma. And we had the workshop with the community, so we can be more sure of the findings. In terms of the limitations, the participation was not compensated financially, so it means those who needed to earn more or didn't have enough free time and resources to participate might not have been able to. And this is reflected in that the majority of respondents were white and indoor workers, so only 11% were racialized workers. So again, we need more knowledge and more understanding and more documentation of workers' experiences with racism in healthcare settings, and the same thing with regarding to street-based workers. Only 7% of the sample were current or formerly street-based. So due to the fact that the survey was online and only in 4 languages, this may have prohibited those who were unhoused, did not have access to the internet, maybe have lower literacy and so forth from participating, so that might skew results. No one disclosed being undocumented. Again, that might be due to fear of actually putting that in a form. So we need more understanding of how documentation status links to healthcare discrimination. We're not really able to generalize to workers in Central Asia because all of the respondents were from Europe. It was a small sample size, so there's no statistical analysis. And surrounding Belgium, that is a very a new development in the legal structure, so we need to be a bit more cautious with the results. So I think we have 45 seconds for questions.
Hello. Thank you so much. I wanted to especially thank Elizabeth because she really jumped in September and analyzed all the data and wrote this in like a very short period of time, so it's really impressive. I'm actually not going to give time for a question and answer. You can talk to Elizabeth directly and ask questions because we are really running out of time, and so I wanted to bring Mark and Layla directly, and then maybe there's a bit of time during Mark and Layla generally about the topic. So sorry, because we're really late. Thank you so much, Elizabeth. So ideally, how long? Because we can... All right, great. So we can finish by 1. Okay, so I let you introduce everything. It's okay? Yeah, that's fine. Okay, go. Thank you so much. Sorry for the delay.
Well, hello everyone. Nice to see you all. So my name is Mark Ferbrache. I work for Terrence Higgins Trust. I'm also a BDSM professional. But in my civilian work, what I do is I focus on health inequalities, so I link sexual health services with sex workers and try and accommodate sex workers within sexual health settings. So I'll do things like increasing access to PrEP for women or non-binary trans people. I'm spreading kind of knowledge on how to do like a sexual health certification for adult performers so that it can be replicated around the country and kind of doing products like that. I'll let Layla introduce herself.
Hiya, I'm Layla. I'm a full-service sex worker from the UK. I also work as a stripper and stuff. I'm a member of the Sex Workers Union, formerly United Sex Workers in the UK. And I'm a parliamentary strategist with UK Decrim Now, who sort of politically lobby in like various public affairs stuff for full decriminalisation. And yeah, we're here today to present a workshop that we did sort of a couple of years running now in collaboration with a professional from an educator even at the University of Bristol where we both live. They can't be here today just because of like admin stuff at the uni, but we've got a little bit from them, some clips that we'll play later. So basically what we did, do you want to go to the next slide? We've got some ground rules. If there are any questions or if we have to cut anyone short, it's not personal. However, we're going to have a little bit that was going to be an open workshop at the end where we were going to ask people on their tables to do a little discussion, you'll see. But we probably won't have time for that now, so we'll encourage you all at the end to come find us at some point this week and talk to us, so that won't necessarily be as relevant. But next slide, please. But yeah, so we were invited by Dr. Jo Hartland, the doctor I was telling you about, who is an educator at the University of Bristol, to be part of their 3D access training at the university. They've been doing this for a few years now, and their whole idea was to teach medical students early on in their education about sort of patients with complex needs or problem patients, which is a problematic term. So you've got people who are unhoused, people who are in extreme poverty, drug users, sex workers, various other complex groups. And we were invited by them a couple of years in a row to be sort of sex workers who talk to the medical students so they can kind of get a more hands-on understanding of our experience. And we are here just to kind of present what we did and to suggest and encourage replication, ideally amongst sex worker groups and advocacy groups and healthcare professionals in other countries and other universities and institutions.
So in like what we kind of came and talked about as people with lived experience of sex work was our experiences in trying to fill out sex workers as like a 3D human person rather than just like something that is pathologized or just empty shells, as was in Lizzie's presentation. So we kind of had different angles presenting like different journeys and perspectives throughout. Do you want to do the next slide? So, as sex workers, we thought this was important because many of us have had to engage with medical staff. A lot of this I don't need to say now because it's literally been like the last hour and a half talking about it. But with, like being dismissed, being kind of not listened to, or being discriminated against, and we think it's really important, and it is really important to inform people, medical staff, really early, so that it colours the rest of their medical education, so that they kind of like learn sympathetically. So we're kind of like trying to get them early to create a new generation of medical professionals that can actually perform their duty of care to a kind of serviceable level. A lot of medical students medical students typically come from a very privileged position and therefore don't necessarily have a good education or like any or much experience with people with kind of intersecting levels of oppression. So it was really important to talk about like unhoused people, LGBTQ communities, as well as talking about sex workers or generally people experiencing poverty. We thought it was important to kind of have sex workers in the room because we look like normal people. Surprise, surprise. And it kind of, especially like having two quite different people as well, kind of goes to combat that idea of them being just a slim, blonde white woman with large breasts. So yeah, it was really important to kind of do it early in their training, just to kind of really allow them to question what they're hearing throughout the rest of their education. Do you want to do the next slide, please? Yeah, you may.
Yeah, as Lizzie said, like lots of various forms of discrimination. I know I personally have experienced it in mental health care settings. I had to break up with a previous therapist over sort of excessive focus on sex work. I've also had access to reproductive care blocked and emergency contraception blocked, like real frustrations. And those instances were actually by medical professionals who were employed by the University of Bristol, which is where we did this training. So that was a bit frustrating. In the talks that we did, we talked sort of each personally first about our own experiences of sex work, how we got into it, kind of demystifying like any of the stereotypes they might have around us, but also kind of filling them in on legal models, kind of giving them a little bit of information about the sex workers trade union, explaining decrim as sort of in the context of HIV transmission and other stuff they probably won't be learning about but need to. Yeah, next slide, please. Again, yeah, we've spent the last sort of hour hearing about it, but yeah, horrific. Can you go back to Stigma? Sorry, that's it. Sorry, I'm like, my brain's all over the place today. Yeah, so we know, obviously, that sex workers are at the intersection of poverty, disability, queerness, etc. That makes us really vulnerable to violence. And we wanted to impress upon these students that they have a massive responsibility, obviously, to in how they approach sex workers who disclose information to them, with the consequence being that sex workers who feel that they are going to be judged or criticised or worse, blocked access to treatment, will not be disclosing or even accessing any care. After all, we know that the World Health Organization advocates for full decrim and make it very clear that one of the reasons they do so is because they believe that criminalisation and stigma obviously go hand in hand to perpetuate like harmful violence against sex workers, and both need to be tackled together. And it's only with full decrim that we can also remove the stigma surrounding us so that we can receive adequate care. One line we impressed upon the students in this training is that we sort of combating that paternalistic sort of attitude. We believe that everyone makes the best decisions always in order to survive. That is just like a bottom line for drug users, for sex workers, for all of us. And we don't need to be patronized. Next slide, please. Oh, other one. From Merge. And now we're going to play a few clips from the doctor who ran this teaching at the uni, who can't be here today, but about how they set it up and what their goals were. So, yeah, you can read it. Dr. Joe Hartland, who used to be an NHS doctor for some years, but now is quite a public queer health activist.
Unfortunately, we had some tech problems, so we're not able to merge the two. But are we able to play the audio? Oh, yeah, there we go. Everyone say hi, Joe. Hi, Joe. Yeah, thank you. Yes.
I'm Deputy Education Director at Bristol Medical School. We're focused on student equity, diversity and inclusion and how we bring the voices of marginalised people in healthcare curriculums. I'm so sorry I can't be with you there. We've been partnered with our speakers today who are delivering this. I'm going to give a little bit of context on some of the slides, so you'll see me pop up every now and then in a video to demonstrate why I think a particular topic is important, or to share with you some of my own thoughts on this teaching and why or how you might be able to go about integrating it into your own curriculums. So I thought it would be useful. So I thought it would be useful to provide a little bit of context for what we've been doing at Bristol Medical School. So I thought it would be useful to provide a little bit of context for what we've been doing at Bristol Medical School. We have quite a broad curriculum that's relatively new. It's been running for about 6 years. And within that, we have the 3D theme that talks about how we examine the forms of bias that we bring to clinical practice and what we can do as healthcare clinicians to think about challenging those biases. And over about 2-3 of the last years, we've been thinking about how can we expand that. And one of the ways that we wanted to do that was to integrate the voices and the needs of sex workers into the curriculum. And we did this by thinking about how we could co-produce with the community, and with the support of the Terrence Higgins Trust, we're put in contact with speakers. And we wanted to see how we could integrate those marginalised voices into the curriculum, but also using an intersectional lens to explore how disadvantage and oppression play out. In particular, for the sex workers' health, we wanted to think about how students might become more aware of the complex relationship between social inequity and health inequity, to reflect on the personal biases they might have towards sex workers and the impact that that might have on healthcare delivery, so that they can start to challenge those biases. Understand what sex workers might need from doctors, so to hear the voices of our speakers, to communicate some of those needs, although we acknowledge that it's really difficult to reflect the whole spectrum of sex work. But with a focus on understanding health needs, importance of certain types of language, and also challenging the stigma that is experienced in healthcare. And then finally, to think about how are we empowering our students to be agents of change for the future, so that they can go into workplaces, into medicine, and create safer spaces for sex workers who are coming in with healthcare problems that they need addressing. I also wanted to give the perspective of why, as a doctor and as an educationalist, I felt this was important, and why at the medical school we think it's important to include these stories. We think it's really important because of the need for destigmatization. Whilst there are very complex legal conversations to be had around sex work in the UK and globally, one of the things that is really important in healthcare is we destigmatize this enough that our staff can have safe conversations with sex workers who need to be able to disclose their work to their healthcare professionals. We wanted to think about how we challenge the bias that people might have and start getting them to reflect on that and evolve their understanding. And within that, also think about this concept that we see a lot in medicine. And often what we mean by the problem patient is someone who is, inverted commas, complex. I don't really agree with that as a term, because I think often complexity and problem patients are just really many people's norms. It's just that the privilege of healthcare staff prevents them from seeing that those are some people's lived norms of everyday life. And it's really important that medics also understand the relationship to wider health and social deprivations, which sex work often intersects with. So we might have to talk about the impact of unstable housing, problems accessing and barriers accessing healthcare, thinking about the prevention of transmissible diseases, but also how other forms of oppression intersect with things like sex work, so around gender, racism, transphobia, homophobia, all of those issues. And this is a very important thing for our students to recognise and take away. And I think this session provides that. So I wanted to give you my top 5 tips for educators, and I know that we're also going to have some tips for our community workers as well. My first one is to think about how is this not just a single event, but part of an embedded culture of compassionate and challenging education within your curriculum. I actually didn't receive very many barriers to putting this session in, and I think that's because my colleagues are used to me bringing up issues and challenging stigma and thinking about how oppression intersects. And so this wasn't the first thing I did when I came into role. It was about 3 years in that I started exploring the integration of sex work into the curriculum. And I think that was probably quite important to kind of have that gradual increase in conversation and thinking about changing people's perceptions on what is acceptable for us to be talking about. I think it's really important as my second tip for us to be co-producing with those who have lived experience, whatever the marginalization is, but especially around this topic. This is not something that I was able to provide a lot of insight into personally, but it is something that I was able to speak about with our speakers who you have here today and with the charities involved. And I was able to share my perspectives as an educationist and a doctor and the outcomes that I need to meet within our end goal of the curriculum mandated by the General Medical Council and align those with the needs of our speakers in a co-production. I think it's also important that we ensure a reciprocal benefit for speakers, and I think in this case one of the primary things that we spoke about as a team was what would be beneficial, and that was pay. Ensuring that we are recognizing that people's time is money and that we reflect that and that we make sure that we are acknowledging their expertise as patients who come in with lived experience, and as we do with many other topics. And that is what they're described as on any financing that we do, lived experience experts. I think it's also really important to have some knowledge and to do your homework. Whilst this wasn't a topic that I was super familiar with, I tried to do my own research and understanding so that when I came to have conversations with our speakers and charities, I was able to say, these are the things that I've looked up and thought about, but I would really like your perspective on this because I want to understand whether or not I'm coming at this with my own biases as a doctor, which was definitely true. Certainly my own whiteness, my queerness, they all play into how I perceive these issues. And so do your homework, think about what you need to learn before you engage in this conversation so that others aren't responsible for educating you. And the last thing I would bring up is the need to work with students, but also especially our speakers, to establish quite a reflexive safety. So that means responding to the issues that are brought up. A lot of our students may be engaging in sex work or may have experience of sexual harm or sexual assault that may come up in the conversations during the day. And it's important they feel psychologically safe to participate. But also that we think about screening questions that might be coming in for our speakers, giving them a chance to look at those questions and think about how they want to respond, so building in breaks and things. And I think we also had to think about what does this mean beyond psychological safety. These are very big groups with about 300 students on average. So how are we bringing people in, preserving them? How are we debriefing afterwards and prepping them for those sessions? And that's part of my responsibility and my duty of care for our speakers as they come in. I hope that's been helpful. I'll hand over the rest of the talk to your facilitators today. And again, I would just reiterate that we're very proud of them and the work that they've undertaken with us at Bristol.
Point that Joe made was their first one about embedding within a culture of like compassionate challenging. So this, for context, this was going to be a workshop where we kind of got people into groups and talked about how we could how people could replicate what we were already doing in your own area. But mercifully, we're cutting that because we want lunch. We want to get everything on time, but what we will be is encouraging people to talk to us about how this can be replicated within your area, because we absolutely want that conversation. But in terms of strategy for replicating, I think it's really good to acknowledge that Joe had already had this track record of bringing in different issues like LGBT, trans, and other communities' issues. So if you're a sex worker advocacy group or a group of sex workers, it's worth finding someone who is already on that journey and latching onto theirs so that you already have a route in. Yeah. But before we...
Yeah, we recognise that, like, I don't know if anyone here is a healthcare professional. I recognise that lots of you are sex worker advocates instead. And there'll be unique challenges to running any kind of training like this, finding an institution and an educator initially to take it on board. Plus all the different challenges. If you're in a Nordic model country, for example, you might have particularly unique challenges presented by the institution. But we are here all week, and we'd love to talk to you more about what we did and how we set that up. And Joe is also a really great contact, so if anyone here would be interested in finding something similar or setting up something similar with a local university, they're really, really interested in talking to people.
Before we go any further, though, can we just have a round of applause for this gorgeous human being being able to kind of work on the fly with tech issues? So Joe's section, the recordings ended in with the tips for educators or healthcare providers. So we kind of put some tips for sex workers going into the other side. So our first tip was to have like very different speakers. So we have been the speakers. We quite apparently look very, very different. Different groups of like people will listen to us. White men love to listen to me, but not Layla, for example. Wonder why. So we kind of identify with different groups. We've got very different journeys, and it paints different pictures, and we can tackle different angles. It's never worth trying to cover everything alone. So it can be a really raw and personal experience because it can be like an hour, 2 hours of kind of trauma dumping. It's a very, our journeys are our own, and you suddenly have to, there was one time where it was coming up to 500 students that we were talking to, and that was a very emotional experience, so it's kind of worth making sure that you're psychologically safe. On to the next point, the student cohorts can be really, really large, so kind of prepare emotionally for that, especially if you're talking about something controversial, which we quite often are seen as. They're also like varying with kind of large student numbers. There's varying opinions, and you will have people who don't want to listen within the cohort, and that's annoying at best. Yeah.
They're also all teenagers, so it's horrible. They're all like 19, it's terrifying. But yeah, Joe, who ran the sessions at Bristol, is amazing, really like knowledgeable and really like empathetic. So chatting to them beforehand meant that we kind of had trust with them, that they had control of the teenagers and the room, and could facilitate that if anything did get out of hand. Luckily, nothing did. You might hear some snickers every now and then, but you have to kind of be steeled for that. But luckily, we had really overwhelmingly positive responses from the students, which takes us on to our last slide, I think. Oh, skip. Yeah, we've done this. We've had students come up to us afterwards to have a chat and tell us how like interesting it was, tell us that they've never met a sex worker before, which they have, but they don't know it, which was like really touching personally to hear, but also like really exciting and interesting to like consider how, consider the benefits if that was to happen on a larger scale. As we discussed already, there are definitely challenges to setting up something like this, but it would be really exciting to like discuss that with other people and see if people are interested in doing that. And then there's just a little bit about the Nordic model underneath it. One thing that came up when we were talking with Joe about challenges that different people would face possibly who are here. I don't know if any of you are from Nordic model countries like France or Iceland perhaps, but in countries like that, we know that while sex workers are technically not criminalised, in reality, they still report facing evictions, fines, deportation, and municipal laws are still used to do those things. And medical practitioners are just another tool that the state uses, just like they use them to block people at borders, etc. And it's crucial that we do this work really early in students' educations to ensure that they have the conscience as they go forward to not be manipulated into tools that the state can use for border control and for general violence against sex workers.
But yeah, so to kind of end this conversation, we won't make you talk to each other. We are merciful, but if you would like to talk about how it can be replicated within your area, or also if you want to talk about anything to do with sexual health, PrEP for women, or also DoxyPEP, we are both, well, Layla and I are here for the kind of strategic conversation, and I'm here to talk about anything to do with sexual health and sex workers as well. But thank you very much for listening to us, and also... And here comes Luca to bring you to lunch.
So it's exactly 1 p.m. Do you want to, Elizabeth? Do you want to come here and then maybe there's a few questions and... Thank you so much for your presentation and for your work. And I think the best, because we are being live streamed all over the internet. And so when you ask a question without the mic, all the people on the internet, they can't hear you. So the best is you ask a question, either with the mic, or you repeat the question. Let's just repeat the question. Okay, I'll let you. There is also a second mic. Yeah. Okay. Question?
I can just say the question you repeated.
Yeah.
Where you, if you medical professionals should start, for people that have no idea, working with sex workers or whatever, where would be a good starting point for medical professionals or anybody in the healthcare field to start to try to tackle things that they see happening?
Cool. So the question was just where medical health professionals who may not have experience with sex work should start with this kind of training in the first place. In Bristol, what Joe Hartland did at the university was reach out to us through Terrence Higgins Trust, where Mark works, which is a charity that does general sexual health testing with a focus on, and management with a focus on HIV. We're also both members of the Bristol Sex Workers Collective, so we have that connection. And they found us through those. And that's probably the best tactic for either side to take, whether it's an advocate approaching the program or a medical health educator approaching it to find sort of the best inroads. Does that make sense?
As to kind of just answer from a slightly different angle, the obnoxious response is Google. Yeah. But I'm pretty sure that there isn't a single sex worker advocacy organization that wouldn't point towards someone else. So if you in Spain reached out to BSWC, or a doctor in Spain reached out to BSWC, I'm pretty sure we would point that person towards you, for example. I'm pretty sure we're all kind of an allied front. So anyone that you can find would be a valid person to reach out to.
Any other question? I'm going to bring the mic.
Hi, thank you all for the presentations as well. It's been really interesting. My question was for Lizzie. There was one particular quote from the presentation and from the research that you mentioned, which was I need to hide my C-section scar. And then you said that you were going to talk a bit more about, or there was going to be more discussion on stigma against parents. I was just wondering if you could maybe go into a bit more detail, and maybe was that a reference to the fear of people finding out that you're a parent and therefore you're not. There needs to be further investigation or whatever.
Yeah, thanks. I think it was just a timing issue. I didn't, I wasn't able to get into all these kinds of granularities with different identities. But there's a lot more information in the report as well. So that would be a good to have a look at. But yeah, relating to parent sex workers, most sort of talked a lot about fears of having children taken away, having custody revoked, having child services involved, just for the sheer fact of it being known that you are both a parent and a sex worker, and the sex work being seen as something that automatically precludes someone from being, you know, a competent care provider. So for that particular quote, that was the issue, was that just having fear of it being known that they were a parent. And yeah, you can see more about the experiences of parents that were shared as well.
Any other question? I don't even look at the room, so I have to go. Huh? Okay, thank you so much. Thank you again for joining us and these amazing presentations. I'll give. It is now lunchtime. About the lunch, it's on the first floor. There should be enough food for everyone because we booked for 75 people. If you are vegetarian, vegan, gluten-free, just tell the waiter, waitress, they will give you. We have 90 minutes for lunch, and we will come back here 90 minutes later. And there was something else? And I think that's it.
We can take it and we can. you.